Welcome to proactivephysioknowledge.com. Today I am giving you some information about the proprioception and its relationship to motor recruitment and pain. Effective movement function, postural regulation of alignment and balance. The dynamic body's balance are more complex than just the muscle's ability to produce enough force. To take place at the proper moment for the right amount of time and with the right force combination, muscles activity needs to be carefully coordinated. This coordinated activity extends to agonist and antagonist muscles connection, and it happens within the group of muscles that are functionally synergistically working. It calls upon a sensory, biomechanical, and a motor processing technique, as well as it acquired reactions from prior experience and the ability to anticipate changes. A key sensory method for motor control is proprioception, which comes from the muscles. Proprioception is related to three main feelings. The one is sensation of position and movement of the joint. The second one is sensation of force, effort, and weight. And the third one is sensation of perceiving timing of contraction, which was cited in 1992 by Gandvia et al. Now about the proprioception and the recruitment pattern. When the joint injury occurs, it may lower the alpha motor neuron excitability and reducing the voluntary activation and abnormal articular affection information. When the articular joint damage, it may decrease the gamma motor neuron excitability and results in proprioceptive deficit that was cited in early 90s. Also, it has been demonstrated that a muscle exertion lowers the shoulder's proprioception repositioning accuracy, which was cited in Voigt in 1996 paper. They find it out that in unstable shoulder, there is a severe abnormalities in both kinesthetic sensitivity and repositioning of accuracy. According to the Grimby and Henners et al., they showed that decreasing efferent intake, like proprioception, it alters the recruitment order of motor neurons and reduces the dominance of tonic motor neurons. They hypothesized that decreased facilitation from the major muscle spindle terminals was partially responsible for the low relative firing of tonic motor units. According to Gandvia et al., they reviewed the relationship between the sensation of motor command of effort and the reflex effects on the motor neuron pool. He reported that there was an increase in perceived heaviness when the muscles has been weak due to fatigue. Neuromuscular blockage changes in the land tension properties. So when you find it out the person has a heaviness for performing the movement pattern, we may give a label that the person may have a weakness due to fatigue or what I have mentioned earlier. An increase in perceived heaviness would be expected when the motor neuron pool was reflexly inhibited. Grimley and Hazard et al., they indicated that when efferent input was decreased, the sense of effort necessary for activation of slow motor units which was increased. This is during the low load activity, the subject perceived that they must try harder to perform the range of motion. It felt much easier and less perceived effort was required to contract the same muscles under the higher load or against the resistance. The clinical implication of this is that when maximum or a higher perceived effort is needed to perform a low load activity or a movement, then it is most likely that there is an inefficient facilitation of slow motor unit recruitment and dysfunction of normal muscle spindle response. However, for the same reason, it is likely to know that slow motor unit recruitment is better supported when there is a less perceived effort required to carry out the same low load activity or movement. A strong clinical signs of increasing stability function is a decrease in a perceived effort needed to conduct a sustained low load exercise that was been stated by Sarah Motam and Comfort in 2000. Now, what is the relationship between the proprioception and the pain? If you look at many studies in early 90s, they revealed the significant reduction in a cervical kinesthetic sensitivity and repositioning capacity, which was linked with the pain and loss of cervical function. Proprioception abnormalities linked to the lower back pain are the subject of a smaller number of trustworthy investigators. Researchers like Gill and Colgan et al. They found that patients with low back pain had significantly reduced the capacity to reposition themselves. They came to the conclusion that exact muscle spindle input was necessary for proper pelvic and lumbosacral spine alignment. Again, in early 90s, Wolf et al., the transmission of nociceptive signals from muscles to the spinal cord and the higher centers of the central nervous system may be blocked or inhibited. A broad diameter as a proprioceptors and the mechanoreceptor fiber synapse on interneurons. This prevents the large dynamic range receptor supporting the paliospinothalamic system in lamina 5 of dorsal horn of nociceptor signals. This is a possible method through which a lack of afferent proprioceptive input may directly contribute to the emergence of central sensitization and evoked pain, which resulting in phenomena of mechanical allodynia. So in summary, when your patients have a difficulty to perform a simple range of motion with lots of effort, it indicates that it requires a recruitment of slow motor unit. Thank you for listening. If you like this, don't forget to share with your friend. And don't forget to visit the website proactivephysioknowledge.com and download the application from an app store.